Welcome to another deep dive.
Glad to be here.
Today, we're plunging into a topic that's incredibly complex, really critical for horse health, equine ileus.
hmm
Now, if you've ever heard the term colic and maybe thought it was just, a bellyache, well, prepare to have your mind expanded a bit.
Yeah, it's definitely more complicated than that.
Our mission today is to try and cut through some of the clinical complexity, give you the most important nuggets of knowledge from our source material on this challenging condition.
It's a fascinating area, I think, because it truly highlights how interconnected various bodily systems are in the horse.
Right.
How a seemingly straightforward gut issue can have these really deep systemic roots. That's what makes it so tricky sometimes.
Okay, let's unpack this then. When most people hear intestinal obstruction, they often picture, well, a physical blockage, don't they? Something physically stopping things up.
Yeah, like something got stuck.
But what struck me from the research we looked at is that ileus in horses is often far more nuanced than just that.
That's right. While the general definition of ileus does include any intestinal obstruction that impairs transit, in horses, we predominantly mean the functional inhibition of propulsive intestinal activity.
Functional inhibition, so the movement stops.
Exactly. It's essentially a failure of the gut to move its contents forward, kind of regardless of the underlying cause.
So it's really about the gut's motility failing, almost like the digestive system goes on strike.
That's a good way to put it.
And what's fascinating here is how crucial it seems to be to distinguish this functional problem where the gut just stops moving properly from a mechanical obstruction, where there is an actual physical blockage.
Yes, that distinction is key.
But the sources also make it clear that a mechanical obstruction can actually lead to functional ileus. It gets complicated fast.
Exactly. Functional obstruction, or ileus, means decreased or absent intestinal motility without a physical blockage getting in the way. The primary problem is a failure of the muscle contraction and coordination needed.
Okay, and here's where it gets really interesting for me, because these mechanical obstructions, even though they are a physical blockage, can cause a functional ileus proximally, further up the gut.
That's correct.
So what kinds of mechanical obstructions are we talking about here? What does the research show?
Well, the sources list several key types. We can kind of group them. First, you have non-strangulating obstructions, where the blood supply to the intestine is still intact.
All right.
These include various impactions, like ileal impaction that's often from coarse hay, maybe poor teeth, or even tapeworms.
Ah, tapeworms too.
Yeah. Then there's ascarid impaction. You see that in foals with heavy worm burdens. Large colon impactions often happen at the pelvic flexure, a common spot. And sand impactions.
Sand, right.
Also things like enteroliths or fecaliths. These are sort of mineral or fecal concretions, like stones.
Yeah.
And then displacements, like nephrosplenic entrapment, where the colon gets stuck, and stenosis or strictures, which are basically narrowings of the passage.
So a whole range of things that block the path but don't immediately cut off blood flow.
Correct. But then you have the other category.
The more serious ones.
Exactly. Strangulating obstructions. Here, the blood supply is compromised. These are absolute surgical emergencies.
Because the tissue starts dying.
Precisely. They cause rapid tissue death and inevitably lead to functional ileus further up the gut because of the severe inflammation and pain involved.
Right. What are some examples of those?
Examples include things like small intestinal volvulus, that's a twist. Strangulating lipoma, which is a fatty tumor on a stalk that can wrap around and cut off blood supply, actually quite common in older geldings.
Interesting.
Epiploic foramen entrapment, mesenteric rents tears and the supporting tissue into the susception, where the intestine telescopes into itself. And large colon volvulus, another type of twist. It's a very critical situation. Immediate surgery is needed.
Understanding what ileus is and all these different ways it can happen naturally makes us wonder why. Why does the gut just stop working?
Good question.
Our sources point to a really complex interplay of factors, especially when we talk about postoperative ileus, or POI. That seems to be a huge issue after colic surgery.
It is. And if we connect this to the bigger picture, the pathophysiology, the why, is truly multifactorial. It's not just one thing.
Not just one switch being flipped.
No, it's a whole cascade of events. Several things happen, often at once.
Okay, break it down for us. What are the key players?
Well, first, there's neurogenic inhibition. Think of it like the horse's stress response slamming the brakes on the gut.
Fight or flight.
Exactly. Stress, pain, even just gentle surgical handling can activate the sympathetic nervous system. This releases norepinephrine, which inhibits the main go signal, acetylcholine. So motility basically shuts down. Even complex reflexes involving the brainstem are involved.
Wow. Okay, so the nerves are part of it. What else?
Then there's inflammation, big one. Surgical manipulation, any damage to the bowel wall triggers a local inflammatory response right there in the gut wall.
Immune cells kicking in.
Right. Immune cells release inflammatory mediators, things like prostaglandins, nitric oxide, certain cytokines like TNF-alpha, IL-1, IL-6. These directly mess with the smooth muscle and nerve function in the gut.
And does inflammation elsewhere matter?
Yes, systemic inflammation, often from endotoxins leaking out of the compromised gut, can make the local problem even worse.
Endotoxins. Nasty stuff. Okay, what's next?
Pharmacological effects, the drugs we use.
Hmm.
Certain anesthetic agents, and especially opioids used for pain relief like butorphanol or morphine, can significantly depress GI motility.
So the treatment itself can contribute?
It can. Even NSAIDs, while vital for pain and inflammation, can have some downsides if not used correctly. It's a balance.
A difficult balance, I imagine.
Very. Then critically important, electrolyte imbalances. Things like low potassium hypokalemia and low calcium hypocalcemia. These often happen because fluid gets trapped in the gut and refluxed out.
And those minerals are needed for muscles to work.
Exactly. They directly impair the smooth muscle's ability to contract properly. No contraction, no movement.
Makes sense.
And as fluid and gas build up, because nothing's moving, you get bowel distension and mural edema. The bowel wall stretches.
Which probably makes things worse.
It does. The stretching itself further inhibits motility. Plus, it can compromise blood flow within the wall, leading to swelling edema and more functional issues. It's a vicious cycle.
Seems like it. Is that everything?
One more key factor, microbial dysbiosis and bacterial overgrowth. When things stop moving scases, bacteria have a chance to multiply like crazy, especially in the small intestine, which should normally be pretty clean.
And that causes problems.
Oh yeah. More gas, more distension. And a really big concern is bacterial translocation bacteria escaping the gut into the bloodstream, leading to endotoxemia.
Which is that systemic infection you mentioned.
Right. Very dangerous.
So what does this all mean for you, the listener? It means a horse with Ileus isn't just dealing with a simple blockage. It's facing this cascading series of problems across its nervous system, its immune system, its muscles.
Whole system breakdown.
Exactly. And often made worse by the very treatments needed for pain. Which really raises an important question about how vets navigate that fine line, balancing crucial pain relief with these potential side effects on gut motility.
It's a constant challenge in equine medicine.
Given this incredibly complex internal struggle then, what are the outward signs? What should make someone suspect Ileus in their horse?
Well, the clinical signs can unfortunately overlap with other types of colic, which makes diagnosis tricky sometimes.
Right. Colic is such a broad term.
It is. But certain features are highly suggestive of Ileus. Historically, an owner might first notice the horse is depressed, showing mild to maybe moderate colic signs, not eating anorexia, and maybe constipation.
Okay. And then when the vet does a physical exam, what specific things stand out?
You'll often find an elevated heart rate, maybe an increased respiratory rate too, and definite signs of dehydration, because all that fluid is getting trapped in the gut instead of being absorbed.
Makes sense.
A really key finding on abdominal auscultation, listening to the gut with a stethoscope, is an absence, or at least a significant reduction, of borborygmi.
Those normal gut sounds.
Exactly. The lack of those gurgling sounds is a big red flag. Then, on rectal palpation, the vet might feel distended, swollen loops of small intestine, or maybe large intestine.
And the source material we reviewed mentions a really crucial sign, especially for small intestinal ileus, that's both diagnostic and helps with treatment.
Yes, nasogastric reflux. Very important.
Tell us about that.
Because the stomach fluid can't move forward due to the lack of motility, it just builds up in the stomach. Passing a nasogastric tube, a tube through the nostril down into the stomach, allows that fluid to drain out.
Which must provide some relief.
Huge relief. It prevents the stomach from rupturing, which is a fatal risk, and eases pain. But it also allows us to measure how much fluid is coming out.
And why is that important?
That volume is critical for guiding intravenous fluid replacement. If you get large volumes back, the sources say specifically greater than maybe 2 liters on one go, or more than 1-2 liters per hour. If you keep tubing, that's highly significant. Point strongly towards a loose.
Got it. Beyond the physical exam and the reflux, what about lab tests or imaging? How do they help confirm things?
Lab tests can show several things. An increased PCV packed cell volume indicates dehydration. You might see azotemia, which suggests kidney function is affected by the dehydration or poor perfusion. Protein levels can go up or down.
Oh, okay.
And crucially, you often find those electrolyte imbalances we talked about: low potassium, low calcium, low magnesium, low chloride, low sodium, all because of the fluid trapped in the gut.
And those directly impact motility.
Correct. Then there's imaging. Abdominal ultrasonography is incredibly valuable.
Ultrasound.
Yes, it allows the vet to actually see distended, fluid-filled loops of intestine directly and assess whether they're moving or just sitting there stagnant.
Very useful.
Extremely.
So, okay, we've got the potential causes, the complex why, the signs, the diagnostics. What does all this mean for treatment?
Well, the good news, if you can call it that, is that simple functional ileus is primarily managed medically.
Without surgery initially.
Yes. But if there is a mechanical obstruction, or if medical management isn't working, then surgery is absolutely necessary. And that surgery itself often leads to intensive medical management for, you guessed it, postoperative ileus.
POI again. It seems unavoidable sometimes.
It's a major hurdle. But the overall aims of treatment, whether medical or post-surgical, are quite comprehensive. You need to decompress the GI tract.
The nasogastric tube.
Yes. Reduce inflammation and pain, try to stimulate motility, maintain hydration and electrolyte balance, support the gut lining, the barrier function, and prevent cardiovascular problems. It really requires inpatient intensive care, 24-hour monitoring.
Right. So what are the absolute cornerstones of that medical management, the real must-dos?
Number 1, frequent nasogastric decompression. Absolutely critical to prevent gastric rupture. Cannot emphasize that enough.
It's life-saving.
Truly. Number 2, aggressive intravenous fluid therapy with crystalloids. Vital. The horse can't absorb oral fluids, and they're losing huge amounts into the gut.
Replacing what's lost and what's reflux.
Exactly. And tied to that is electrolyte correction, especially potassium, calcium, and magnesium. You have to normalize those levels to give the gut muscle a chance to work again.
Okay, fluids, electrolytes, decompression. What about the inflammation and pain?
Right. Anti-inflammatory and anti-endotoxemic therapy. NSAIDs like Flunix and Meglumin are standard for pain and inflammation.
Like Banamine.
Yes. And then a real cornerstone, especially for POI, is lidocaine, given as a constant rate infusion and IV drip.
Lidocaine, like the local anesthetic.
The same drug, yes, but given systemically at a low dose, it does several things. Suppresses those inhibitory nerve signals, acts as an anti-inflammatory itself, provides pain relief, and might even help protect the gut lining from potential NSA side effects. It's become really central to POI management. Other options might include polymyxin B to bind endotoxins and pentoxifylline to help with microcirculation.
And what about actually trying to stimulate the gut to move? Prokinetics.
Yes, prokinetic agents. These drugs are designed to stimulate motility, but their effectiveness can be variable, and they have different considerations. Well, metoclopramide can sometimes cause excitement or neurological side effects in horses. Erythromycin, an antibiotic, has prokinetic effects, but maybe less so when there's significant inflammation, and it can cause diarrhea. Cisaprod is another option, sometimes needs special compounding. And neostigmine, which works differently, has to be used with extreme caution because it can cause widespread effects and potentially severe colic if not managed just right.
So not simple kickstart drugs.
No, they need careful selection and monitoring. Then there's pain management beyond just NSAIDs. Alpha-2 agonists or opioids might be used, but carefully, like we discussed, because they can temporarily inhibit motility themselves.
That balancing act again.
Always. And finally, diet and activity. Initially, food and water are withheld. Then, as things improve, diet is reintroduced very slowly and gradually. Frequent, gentle hand walking can also help stimulate GI movement.
And I saw mention of preventing complications, too.
Yes, a big one is laminitis. Because of the inflammation and endotoxemia risk, aggressive cryotherapy, continuously icing the horse's feet, is highly recommended as a preventative measure.
Makes sense. So that's the medical side. What if that's not enough, or if a mechanical blockage was suspected right away?
That's when surgery comes into play. An exploratory laparotomy, basically, opening up the abdomen to look, is indicated for known mechanical obstructions, or if medical management just isn't resolving the ileus.
Again, what happens in surgery?
The surgeon finds and corrects the mechanical problem, untwists the volvulus, removes an impaction, frees an entrapment. If any section of the intestine isn't viable, meaning the tissue has died from lack of blood supply.
It has to be removed.
Yes, it's resected, removed, and then the healthy ends are surgically reconnected. And anastomosis.
Major surgery.
Very major.
Yeah.
But even after a successful surgery, Fixing the mechanical issue, these horses are, as we've said, at very high risk for developing POI, so they immediately need that same intensive medical management we just outlined.
It really circles back, doesn't it?
Yeah.
Okay, so after all that, the diagnosis, the intensive care, maybe surgery, what's the expected course? What kind of prognosis are we looking at for a horse with Ileus?
It's highly variable, really depends on the underlying cause, how severe it is, and crucially, how the horse responds to treatment.
Any generalizations?
Well, simple functional ileus, if caught early and managed with good supportive care, generally has a good prognosis. The horse recovers. However, postoperative ileus, POI, after colic surgery, that remains a major concern.
Right. Our sources showed some pretty stark and frankly quite wide ranges for survival there.
Indeed, they do. Survival rates for horses that develop POI after colic surgery, they can be as low as 13%, and up to maybe 86%. That huge range just shows how unpredictable and potentially devastating POI can be. It's still a leading cause of death after colic surgery.
Are there factors that point towards a poor outcome with POI?
Yes, the research identifies several. Things like prolonged reflux or very large volumes of reflux coming back up the nasogastric tube. Developing laminitis is a very negative sign. Severe systemic inflammation or endotoxemia, needing a second surgery or relaparotomy, severe persistent electrolyte imbalances, and, unsurprisingly, having an underlying strangulating lesion that required a resection and an anastomosis removing dead gut. Those cases tend to have a tougher time with POI.
So it really underscores the critical importance of that intensive round-the-clock care and trying to be as proactive as possible with things like lidocaine and cryotherapy.
Absolutely. Early intervention and aggressive, comprehensive support are key.
And that wraps up our deep dive into equine ileus. What we've really learned today, I think, is that it's far more than just a simple blockage in the gut. It's this complex, multifactorial challenge that really demands a sophisticated understanding of how the equine gut works, everything from its neurochemical signals to its inflammatory responses. It's a condition where, sort of paradoxically, the body's own defense mechanisms can end up contributing to the problem.
Which naturally leads us to a final thought, perhaps a question for you to consider. Given the huge impact of postoperative ileus and this incredibly intricate interplay of factors, the nerves, the inflammation, the drugs, the electrolytes, how might future research focus on even more targeted, perhaps preventative strategies? Could we find novel therapies, things that could specifically dampen down those harmful inflammatory and neurogenic responses after abdominal surgery, maybe even before they fully take hold and improve outcomes even further? It's just a testament really to the fact that even with conditions we think we understand reasonably well, there's always more to learn, always more to explore.